Sorry, my mic was muted. Hello and good afternoon to everybody, all in one who are present here. Very well, good afternoon, very warm good afternoon. I'm Dr. Himanshu Mathur on behalf of Jaipur Rehab. I welcome you all again for the second part of the much awaited biomechanics session of the hip joint. So we did something yesterday. We had a few things regarding the torque. We had a few things regarding the lever. We understood how the movement of the joint takes place and how the muscle action, what is the muscle force, what is the momentum. We saw that all yesterday. And I think that was pretty much understandable. If by anyhow, if it is not understandable to you, do join me on either you can join me on Telegram or you can just talk to me on Facebook, on WhatsApp, on any social media you want to talk to me, or you can also call me at any time if you want, if you have any query. I'm also available on WhatsApp if you want to ask something or discuss or share your doubts. All right. So coming today, we have the second part of the much awaited thing, that is your biomechanics of hip part 2. So today we'll be talking a little more about the pelvic on femoral motions, that is the closed kinematic chain osteokinematics. We'll be talking about muscle interactions. We'll be talking about the force analysis. Okay, so we'll be talking about all these things today. So let me share my screen and let's start the journey. Superb. So I've already introduced myself to you yesterday also, but today also I'll be doing that. Hi, hello everybody who have just joined. I'm Dr. Himanshu Mathur. I'm working as an assistant professor in the Department of Physiotherapy, Jaipur National University. I'm also working as a chief physiotherapist for my physiotherapy clinics, and I'm also working as the director and chief physiotherapist for Jaipur Rehab. Coming on to the topic of the day, that is the pelvic on femoral osteokinematics. So when we talk about the pelvic on femoral osteokinematics, we just have to, we just have to look into account for two things. One is the lumbopelvic rhythm. Okay, the other one is the pelvifemoral motions. Okay, in both the cases, the femur remains fixed and pelvis is free to move. So whenever we talk about the lumbopelvic rhythm, when I talk about this, we talk about the forward bending motion. So whenever, just try and imagine that, what do I say? Okay, so whenever I start for bending forward, there is a particular hierarchy in which the segments of my spine followed by the pelvis, which is followed by the hip joint, the movement takes place in a particular hierarchy. Okay, first of all, I just slouch down, followed by the flexion of my neck, followed by the over flexion of my thoracic spine, followed by the flexion of my lumbar spine. Eventually, when the lumbar spine starts flexing, and after a certain 30 to 40 degrees of flexion, my pelvis starts to go into anterior tilting. Whenever my pelvis starts to go into anterior tilting, there is some amount of flexion which is being aided at the hip joint. So this is what we are aiming at today. So whenever the pelvis is going into anterior tilting, or if the pelvis is coming towards the fixed femur, we call it as the pelvic on femoral osteokinematics. Whenever we talk about lumbopelvic rhythm, there is a compensation of movement during the forward bending. So whenever we go into forward bending, there is a compensation of movement, that if there is a lesser amount of movement, or if there is some hypomobility available at the lumbar spine, in that case, more flexion at the hip takes place, so as to compensate for the lesser moving lumbar spine. Okay. And if in case when there is hypomobility at the hip joint, then lumbar spine compensates for increased flexion of it. All right. So I'll tell you the complete hierarchy and how the muscle action takes place for the lumbopelvic rhythm. Although you might be knowing about it, but still I'll be telling you. the few details about it. Okay, so whenever I slouch down, I start flexing my lumbar spine and my pelvis goes into anterior tilting, and some amount of flexion is being aided at the hip joint. And when I go completely into the forward flexion, complete forward flexion, see, whenever you are going towards the ground or towards your extensor muscles of the spine, all the extensor muscles of the hip joint will work eccentrically, because they are allowing you to go along with the gravity. Okay, so I'll write it down here. So eccentric work of the extensors. Okay, so you have eccentric work of the extensors takes place because they are allowing you to go towards the ground along with the gravity. Okay, whenever you have to, whenever you go into complete flexion or whenever you go into complete forward bending, there is a phase when your extensor muscles of your lower back and even your hip joint stops working. They do not work, and the complete load or the compressive forces comes upon the tensile strength of the ligaments which are there present in the or intervertebral ligament. It comes over there. Okay, so this particular phase is known as the phase of electrical silence, that whenever there is no electrical activity present in the muscles of the extensor compartment of the lumbar spine. Now what happens is, it is because that whenever you try to get up from that particular position, suppose I'll draw a diagram, small diagram over here, if you can just visualize. Suppose this is the hip joint, this is the person, and this is the lumbar spine. Okay, and suppose this is the person in forward bending. Okay, now we consider this as the axis of rotation. This is the mechanical axis going on, and this is the axis, or this is the perpendicular line of the weight of the body. And the external momentum, the distance, the perpendicular distance between these two lines becomes lesser as you go down into forward bending. Okay, so always remember that whenever you are into complete flexion, the external momentum is very less, and so as the internal momentum. The internal momentum of the erector spinae reduces whenever you go into complete flexion. All right, so at that time, erector spinae will never work to get you back or pull you back into extension. In that case, what happens? Gluteus maximus plays a vital role and pulls the pelvis a little posteriorly. When it pulls the pelvis a little posteriorly, the erector spinae gets certain amount of significant momentum, and then it starts firing. So the initial work, the initial muscular work, whenever you come back from the position of complete forward bending, the first muscle to work here is your gluteus maximus. Okay, then erector spinae start working. Fine. So this is what I wanted to tell you regarding the closed kinematic chain osteokinematics of the hip joint. Similar goes with the pelvifemoral rhythm also. In this case, whenever it is not usually the closed kinematic chain, it is also there in the open kinematic chain. So whenever we talk about the extensive movement of, see, whenever you lie in the side lying position and you attempt to go for hip abduction. So whenever you go into hip abduction, after a certain range of hip abduction, there is a certain tilting of the lumbar spine also, and lateral tilting of the pelvis also. So whenever the lateral tilting of pelvis and the lateral bending of the lumbar spine compensates to the increased range of motion of abduction, that is known as pelvifemoral rhythm. Okay, and there is certainly one another thing that I'll be talking about, that we'll be talking about when I'll be telling you about the forces. So that is again a unilateral stance pelvic motion or unilateral stance closed chain movement that we'll be talking about. Okay, now we'll be talking about the muscle actions. Now this is a very vital and this is a very important graph. What I needed to tell you, that if you see that this is the center of your femur, and there are different muscles that comes and attaches here, and they have told you the direction of this graph is telling you the direction of the action of the muscle. So gluteus minimus is the direction of gluteus minimus is this. So it is going anteriorly and superiorly, from anteriorly and superiorly. Okay, gluteus medius is going posteriorly, again superiorly. It is pulling from the frontal plane more. All right. Now this is going, the iliopsoas is also pulling you from anteriorly, it is going posteriorly and pulling you inside. So whenever you see all these forces are being targeted superiorly, although it can go anteriorly also, it can go posteriorly also, but all the muscle forces are targeted superiorly. So ultimately the resultant vector will always be superior, such that they tries to push the head of the femur into the acetabulum. So anyways, we are talking about the movement or the muscle interaction. These muscles always aids for static stability also and dynamic stability also, because of their constant pull or because of the direction of forces of these muscles pertaining to the location of these muscles and attachment of these muscles. They always try to pull the distal articulating surface of the head of the femur towards the proximal articulating surface, and that is your acetabulum cavity. Okay, so you have many more muscles such as gluteus maximus, which is a big muscle. Probably it has the highest cross-sectional area or the largest cross-sectional area amongst all the extensors of the hip. Okay, so it becomes a although adductor magnus is also a potential extensor, but gluteus maximus has larger what do you can say cross-sectional area as compared to that. So the force of contraction always remains higher than all the other muscles. Okay, similarly we talk about the hamstring muscles. So you have some hamstring muscles also, semitendinosus, biceps femoris, you have pectineus here, you have adductor brevis here, you have adductor longus here. Okay, you have sartorius here, you have tensor fascia lata on the lateral side. So if you can see, the resultant vector will always be superior, be it from here, be it from here, be it from posterior, posterolateral, posteromedial, enteromedial, anterolateral, wherever they are, ultimately the resultant vector will always be superior. And that too, if I talk about this, if this is the head of the femur and this is the acetabulum cavity, so the forces will always be directed towards this. The resultant would go like this. Either if it is the gluteus medius, it will go like this. If it is the adductors, it will go like this. If it is the gluteus maximus, it will go like this. So direction may change. It can be anterior, it can be posterior, it can be medial, lateral, but a superiorly directed force will always be there. Okay, which pulls the head of the femur towards the acetabulum cavity. I hope it must be clear to you people. So let us start with our first group of muscles, that is the hip flexor muscles. Whenever you see the hip flexor muscles, you can very beautifully see this particular thing here. That this is the psoas major muscle which is coming. Right. This is the psoas major muscle which is coming. Okay, this is psoas major. Psoas major muscle takes its origin from the early transverse processes of the early lumbar vertebrae and takes its origin till the lower lumbar vertebrae also. So whenever you see that from the site of origin, its cross-sectional area is not too much. It is pretty much close to the vertebrae or to the site of attachment. But as we compare, it goes down to the lower lumbar vertebra, it has a little more distance. So I would like to drag you to the yesterday's class. We saw that to carry out every movement, a muscle needs to generate some amount of torque. And torque was equals to, what was that? Force into momentum. Momentum is your perpendicular distance of the attachment of the muscle to the fulcrum or to the area or to the site where the axis is passing. Okay, so when I talk about the upper lumbar spine, the momentum of this particular muscle is lesser. So by this we can say that torque is also directly proportional to momentum. If the momentum is increasing, the torque will also increase, and if the momentum is decreasing, torque will also decrease. So if the momentum on the upper lumbar spine is lesser for psoas major, the torque generation for the upper lumbar spine by the psoas major will also be lesser as compared to the lower lumbar spine. So by this, I can say that psoas major is a good stabilizer for the upper lumbar spine, and it is a good mobilizer for the lower lumbar spine. I told you yesterday, the muscles which are closely related to the joint are good stabilizers because they have to contract. And if they are contracting, they are trying to stabilize a particular joint, but they do not carry out any movement because the required amount of torque is not being generated by those muscles. Okay. So the psoas major for the upper lumbar spine is a good stabilizer, and the same psoas major for the lower lumbar spine, because of the increased momentum, it becomes a relatively better mobilizer. It can act as mobilizer for the lower lumbar spine in the sagittal plane. That is, it can act for flexion. All right, but today we are not talking about lumbar spine. We are talking about the hip joint. So the where is it? Yeah. So the psoas major comes down and it blends with the iliacus, which takes its origin from the iliac fossa. This is the iliac fossa, and iliacus takes its origin from here, and psoas major blends with it. Now what happens is, whenever it blends, and if when it courses down, it gets attached onto the lesser trochanter. Before it gets to the lesser trochanter, by this pubic ramus, this muscle gets deflected. So now if I see the angle of deflection, so if I see one thing, that if I try to plot a angle between this, if I plot an angle about this and this by the normal, so this angle comes out to be nearly 35 degrees. So in a normal human being, or anatomically when I'm talking about, so the deflection of iliopsoas muscle by the pubic ramus is for about 35 degrees. Now, why do we need the deflection? If we do not had a deflection, then this is the center of the femur, and this is somewhere is the site of attachment. Okay, so because of this deflection, we are getting some amount of momentum. If deflection was not there, the muscle would have come like this. Okay, if the muscle would have come like this, we do not have had any momentum. So in that case, we do not the iliopsoas muscle would not have been able to carry out hip flexion. Because of the deflection present in the iliopsoas muscle, in the course of the iliopsoas muscle, this particular muscle is able to generate or develop some amount of momentum, and this momentum is allowing the muscle to efficiently flex the hip joint. Now let us see what does this has to say. Right. So towards the digital insertion, or distal, I would say distal insertion, the broad tendon of the iliopsoas is deflected posteriorly to about 35 degrees to 45 degrees immediately after it crosses the rim of the pubis, or the ramus of the pubis. Okay. With the hip in full extension, the deflection erases the tendon's angle of insertion to the femur, by thereby increasing the muscles leverage for the hip flexion. That is what I was talking about. This is the increasing the momentum for it. Okay, in hip abducted position, the iliopsoas can assist in external rotation also. All right, so it has a momentum for external rotation also in transverse plane. Okay, the iliopsoas muscle produces forces that crosses the lumbar and lumbosacral regions as well as the hip. Unlikely the psoas major, the psoas minor has little action on the hip muscle. Ideally, it does not have any action on the hip muscle. Okay, so the functional significance of the psoas minor is very less, and it is also not present in almost 40% of the people. All right, so psoas minor may be present, may not be present in a normal human being. Coming on to the overall function of the hip flexors, so we have a very good moving body here that is showing you the complete attachment from the anterior and posterior aspect of this area. So you can see very easily that how the muscle is being deflected and how the psoas has its attachment. You can see here the attachments of psoas in all the planes, rather frontal plane also, transverse plane also, and in the sagittal plane also. You can see that. All right. So the anterior pelvic tilt is performed by a force couple that acts between hip flexors and low back extensors. It means that whenever I talk about, suppose this is the lumbar spine, this is my pelvis, and this is somewhere is my femur. Okay. So I have low back extensors over here. All right. And I have my hip flexors over here. So now, so they both these muscles work as force couple here. All right. So whenever these muscles get tightened, they also get tightened. Okay. So whenever the lumbar lordosis increases, there will be certain amount of anterior tilting of the pelvis, which will cause flexion deformity or aided flexion at the hip joint. All right. This is what is known as lower cross syndrome, if you have heard about it. Okay, lower crossed syndrome. All right. Now, the open kinematic chain, this action requires that the rectus abdominis generate a potent posterior pelvic tilt. It is the same what we have talked about. It is the just reciprocal of it. Okay. Again, when I'm talking about, this is the lumbar spine, lumbar lordosis. This is your pelvis, and this is your femur. Okay. So when I talk about the flexors of the spine, that is rectus abdominis, and extensors of the hip, that is your gluteus maximus. So these muscles also work in conjunction or as a force couple. All right. So they neutralize the strong anterior pelvic tilt potential of the hip flexor muscles. All right. Moving forward, we have another group of muscles, that is hip adductor muscles. All right. So whenever we talk about in the frontal plane, so all the muscles in the frontal plane have just one work: to produce a potential adductor torque. A potential adductor torque is required to be produced by these muscles. Okay. Now, when I talk about the sagittal plane, regardless of the hip position, the posterior fibers of the adductor magnus are powerful extensors of the hip, similar to the hamstring muscle. So, regardless of the position of hip, posterior fibers of adductor magnus, I told you that because it has a certain amount of momentum in the sagittal plane, also the adductor magnus, so it can act as a potential extensor of hip joint. So along with a hamstring being a secondary extensor, we have adductor magnus also, that works as a secondary extensor of the hip joint. Although a major extensor will always be gluteus maximus because of its larger cross sectional area. So you can very beautifully see this diagram, this moving diagram, where you can see the proximal attachment of the adductor muscles also, and the distal attachments of also. You can see the adductor magnus and adductor longus very differentially over here. All right. Now, from a position of at least 50 to 60 degrees of hip flexion, the line of force of the adductor longus is posterior to the mediolateral axis of the joint. At this position, the adductor longus has an extensor moment. Okay, so adductor longus also has an extensor moment over here. Just a second, I need to stop this. Just a second, just a second. All right, sorry for the technical glitch that we had. So I would again like to share this. All right. So I was talking about the hip adductor muscles. So from the hip positioned less than in 60 degrees of hip flexion, however, the line of force of the adductor longus shifts anteriorly to the medial lateral axis. So if you have a flexion of nearly 50 to 60 degrees of hip flexion, the line of adductor longus is posterior to the medial lateral axis. And if it is less than 60 degrees, then it is the adductor longus, the line of force of the adductor longus is shifts anteriorly to the medial lateral axis of rotation. The adductor longus now has a fixed moment arm to generate a flexible torque similar to that of the rectus femoris. In that case, the adductor longus can act as both the flexor and the extensor of the hip joint. Similarly, when we talk about the hip internal rotator muscles, from the anatomical position, there are no primary. See, whenever you talk about, if you must have studied the anatomy properly, you must have been known that you don't have any authentic, or you don't have any classical internal rotator muscles. All right, so it is just the other muscles which substitute or which compensates to become your internal rotators. All right. So from the anatomical position, there are no primary internal rotators of the hip, because no muscle is optimally positioned in the horizontal plane to produce internal rotation torque. All right, it is just the compensation of the other muscles that helps you out in your internal rotation. Okay, it can be your abductors, it can be many more muscles. Let's see. Now, with the hip flexed towards 90 degrees, the internal rotation torque potential of the internal rotator muscle dramatically increases. So, whenever your hip is flexed to 90 degrees, your adductor muscle also can work with your being your internal rotator. Now, flexing the hip close to 90 degrees, orient the line of force of these muscles nearly perpendicular to the longitudinal axis of rotation. Okay, so whenever the axis of rotation is longitudinal, or whenever we flexes our hip nearly or close to 90 degrees, the other muscles have see, if it is let me start with that. Wait. So suppose if this is the hip joint, and if we have flexed the hip to 90 degrees, if it's the 90 degrees flexion at the hip what we are talking about, so there are certain muscles who have their the force of action, or the line of force comes perpendicular to that with the longitudinal axis of rotation. Okay, now interestingly, even several external rotator muscles such as the piriformis, just try to listen what I'm saying right now. Okay, the piriformis can change the line of action or the action of the leverage of these muscles. Okay, now whenever the hip is flexed to 90 degree, piriformis works to be an internal rotator, and whenever it goes beyond that, or whenever your hip is in the neutral position or in extension position, the piriformis works as an external rotator. Okay, so piriformis is one muscle that works as an internal rotator whenever your hip is flexed at 90 degree, and whenever it is at neutral or in extension, it works as an external rotation. So this phenomenon is also known as piriformis paradox. It means it works both as internal rotator and external rotator. So it is a very different and a very celebrating work, or the much discussed, much needed to be known work done by the piriformis muscle. Coming on to the other group of muscles, that is your extensor group of muscles. Extensor group has a very, very, very big muscle, very vital muscle, very important muscle, that is your gluteus maximus. Now, in the extended position, the posterior head of the adductor magnus has the greatest momentum that I told you earlier also. Although in the extended position, the highest momentum is of adductor magnus, but the cross-sectional area of gluteus maximus is too much, so the force production is always more by the gluteus maximus. Okay, the semi-membranous and gluteus maximus have the greatest cross-sectional areas of all extensors, being gluteus maximus being the highest of all. All right. Now, at 75 degrees of flexion, the hamstring and the adductor magnus produces about equal magnitude of extension torque for about 90% of the total extensor torque. All right. So whenever there is 75 degrees, see, always remember the momentum and the torque generation by the gluteus maximus always increases either when your hip is in neutral or whenever your hip is in extension. But if your hip is in flexion, then the major torque generation is being done by either hamstrings or it will be done by adductor magnus. Okay. Now, hip extensor and abdominal muscle act as, I told you that hip extensor and abdominal muscle work as force couple. It allows the the pelvis to go into posterior tilt. So whenever it goes into posterior tilt, it reduces the lumbar lordosis also. Okay, so it's a basic biomechanics. Hello, everybody. Sorry, there was a technical glitch going on. I hope I'm audible and visible to all of you. You can write it in the comment box if I'm audible and visible to you. Am I audible to you, people? All right. If I'm audible and visible to you, people, you can just tell me here. There's some technical glitch going on today because we don't have proper electricity power. We don't have it. I'm just working on uh, the extended support of the power supply. So we are facing some technical glitch that will be we will overcome this very soon. All right. So we were talking about the extensor group of muscles. Thank you so much. So we were talking about the extensor group of the muscles today. Uh, I think we are trying to work on that technical glitch. So we were talking about the extensor group. Now, since we have done with the extensor group, now we have to go on to the very important aspect, that is the hip abductor group. Now, I'll tell you one thing, that we'll be talking about the hip abductors. The major hip abductor with us today is gluteus medius. Okay, the gluteus medius is the major hip abductor muscle. Now, whenever I talk about the gluteus medius in open kinematic chain, we all know that the open kinematic chain abduction is very easy to be performed. Okay, whenever you go into side lying or even in standing position, you can perform hip abduction. So this is the open kinematic chain. It can be substituted by the works of TFL or IT band or things like that. But the major cross-section area, or the major torque production for the abduction is done by your gluteus medius muscle. But whenever I talk about the closed kinematic chain, or whenever I talk about the single limb stance biomechanics or single limb stance muscle interaction for the gluteus medius muscle, then let me show you something, that how does it appear. Okay, just give me a second.
Sorry. Now I hope it's audible. Okay. Now just look at this side of my this pelvis. Okay. I've unmuted myself. Sorry. So this area of my pelvis, you just see that I'm standing in a single limb support. All right. I am standing in a single limb support. This leg of mine is in the air. Okay. So the right-sided limb support I'm having right now. Now, if the right-sided limb support is there, the right gluteus medius is working. Okay, the right gluteus medius is working for my what you can say frontal plane stability. Okay, I have unmuted. So this is working for my frontal plane stability here. Okay, now this is how this is causing frontal plane stability to me. This is causing frontal plane stability by pulling this side of pelvis up in here. Okay, now if this side of gluteus medius is not working, then this side of the pelvis would drop down. Okay, now this side, right side of my gluteus medius is pulling the left side of my pelvis. All right. The same thing happens when we talk about the swing phase of the gait. Whenever I'm into swing phase and my contralateral limb goes in the air, in that time at that time contralateral side of the gluteus medius works to pull the pelvis up in the air to keep in conjunction with the other pelvis. Now, whenever the right side or the stance side, this gluteus medius is working, so it is trying to rotate the pelvis in anti-clockwise direction. Okay, it is trying to rotate the pelvis in anti-clockwise direction. On the contrary, the gravity is trying to rotate it in the clockwise direction. Okay, if I go along with the gravity, this side, the left side of the pelvis would drop down. It will cause adduction at the right side. Okay, now this is how gluteus medius is working. It is contracting from this side such that this side of pelvis is being lifted and there is a abduction on the right side. Okay, I think that is clear. If it's not clear, I'll be taking it again also. Okay.
Hello, I hope I'm audible to you people now. Let me share the screen once again. Now we have something very, very different to be done. All right. Just a second. So we had talked about the okay. Now I'll be talking about the hip abductor muscles. I told you about the basic mechanism of the hip abductor muscles. All right. So now we'll be talking about the most important aspect, that is the role of abductors in force production of the hip. Okay, just give me a while. All right. So now just follow what I'm saying. Although today I'm facing a lot of technical problems, but I think things have been resolved by now. Now, just have a look at this diagram. don't try to read what I've written. We'll be taking it in the last. Okay, just try to understand what I'm trying to tell you here. Okay, we'll be doing some calculations here. By this, we'll be telling you some analysis of forces over here. All right. So what happens is, suppose this is the center of the femur. Okay, so this is the axis point or the fulcrum point. All right. Now this is the site of attachment of gluteus medius. Okay, so this is a perpendicular line which is going going here, and the distance between the fulcrum and this perpendicular line is somewhere d. So d is your internal momentum. Always understand this. Okay, now this is the weight axis. The weight axis passes from the center. So this is the perpendicular line of the weight axis, and the distance of weight axis or the body weight, that is the external load or the external force that I told you about yesterday. So this is your d1, or I'll call it as a capital D. That is your external momentum. Now what happens in context with the frontal plane stability of the hip joint, it is always being said that the internal momentum is half of the external momentum in the cases of external load or the body weight. Or rather, I can say that the external moment arm which is available by the virtue of the body weight is double that of the internal momentum. So here I can say that this bigger d is equals to 2d, small d. All right, that small d is your internal momentum. So always try to consider that. Now you just saw me standing in the single stance condition, right? Single stance situation, you saw me standing there and I was into static equilibrium. All right, now we know one important thing, that okay, I'll write it here only. So in a single support phase, I was into static equilibrium. Okay. Now we know one very important thing. When a person is in static equilibrium, all the forces acting or the resultant forces acting on that particular body or that particular segment is zero. So I can call it as that all the forces acting on that particular area are equal and opposite in nature. So can I say that the internal torque which is being generated by your gluteus medius is equals to the external torque? Easy to be understood. There is no rocket science into it. Now we just saw one very important thing, that torque. What is the formula of torque? The formula of torque is force into momentum. So here when I talk about the internal torque, the force will be muscle force. That is the hip adductor force. All right, that is the force by the gluteus medius. We do not know that. Okay, but that will be multiplied by your internal momentum. Internal momentum was small d. We just saw that. Okay, and it was equals to body weight, the force of the external load or the external force that is generating the external torque is your body weight. So body weight multiplied by capital D, that is the external torque. Now we know that this capital D is your this is the double of the internal torque. So can I write it like this, that hip adductor force multiplied by small d is equals to body weight or the force by the body weight into 2d. We can do that. So I can cancel out this to this. So this becomes hip adductor force is equals to twice of the body weight. Okay, body weight, I'm sorry. In that case, whenever I am standing in a single support phase position on my single limb, and if my pelvis or my hip joint is in static equilibrium position, then the force generated by the gluteus medius muscle is double that of my body weight. So supposingly, if my body weight is somewhere around 700 Newton, in that case, in this particular position, my gluteus maximus will produce a force equals to 1400 Newton. All right. So this is the theory behind it. Now, going back to this slide again. Okay, I just have to remove it. Yeah. So if we have talked about, if we know that what is the force being generated by the hip adductor muscle. So this muscle, I told you that this is trying to pulling this side up. So if this is going anti-clockwise rotation of pelvis, so on the ipsilateral side, it is also causing this type of motion, again the anti-clockwise motion. So the force of the abductor muscle, which is coming here, is downwardly directed. The body weight force is also downwardly directed, but at the same time, the compressive force or the joint reaction force which is occurring between the two articular surfaces is going from down to up. So it is an upwardly directed force. So here we can say that there can be two forces which are equal and opposite, because it's again a static equilibrium. So upward forces are equal to downwardly directed forces, right? Okay, so the upward force is your JRF, that is joint reaction force, and if it is equals to the downwardly directed forces, so downwardly directed force is your hip abductor force plus your body weight. So in the previous slide, we knew that hip abductor force is equals to twice of the body weight. So can I put the same value here? So JRF, or the joint reaction force, is equals to twice of body weight plus body weight. So the joint reaction force here comes out to be thrice of the body weight. So it means when I am standing in single support phase condition, when I am standing in single limb support phase situation into a static equilibrium position, the reaction force or the compressive force between the two articular surfaces is equals to thrice of the body weight. So if my body weight is somewhere around 700 Newton, so the compressive force acting between the two articular surfaces will be equals to 2100 Newton. Okay, so whenever I'm standing in a single support phase situation, the compressive force between the joint surfaces is thrice of the body weight. All right, now let us consider another fact that do we have a okay, we don't have, we will do it here only. Okay, so let us consider another fact. Say suppose I am a say 78 kgs man. Okay, now the 78 kgs man would be somewhere around 171 pounds, which will be equals to around 760.6 Newton. Okay, so that would be my weight somewhere. Okay, so if this is my weight and I consider the internal momentum small d to be somewhere around 4.2 and the double of it, the external momentum, to be 8.4, and suppose there is the hip joint is something like this. Suppose this is the pelvis, this is the hip joint here, this is the hip joint here. Okay, and I keep a cane, a stick on the contralateral side. Okay, suppose this is the side I'm calculating all the forces, and I'm keeping a cane or the stick on this side. So the distance between this and this, the perpendicular distance, would become say 35 centimeters. Let us assume it as. So it is the external momentum again. So we'll be calling it as D1. So the D1 comes out to be 35 centimeter. All right. So can we calculate the hip abduction force now? Now let us calculate the try to calculate this hip abductor force. Now we have two external forces that are acting, or rather than external forces, let us do one thing. Let us try to balance it according to the clockwise rotating forces and anti-clockwise rotating forces. Now when I talk about this what you can say, the hip abductor, the direction of force is downwards because it is trying to pull this up. Similar work is being done by the cane also. So it is also applying a anti-clockwise force, whereas the body weight is pulling it, taking it down. So it is applying a clockwise force. Okay, so now So now let us equalize the clockwise force to the anti-clockwise force, or the same. You can write it either ways. Okay, so the clockwise force is your body weight. Okay, so body weight into capital D, whereas the anti-clockwise one is, suppose the weight of the cane is somewhere around, or the force which the weight of the cane is generating is somewhere around 17 Newton. All right, we can take it like somewhere like that, or 17 pounds. We can take it like that. Okay, so this is capital D. And if we try to see that the internal momentum by the virtue of the muscle action, we know that. So we don't have the value of force here, multiplied by 4.2, and further which is being added with that of the that for this what do you say, that cane, that was somewhere 17 multiplied by 35. Okay, now we have the value of this, we have the value of this. Okay, so if we say that okay, we can put the values of this also here. So we have 760.6 into 8.4. Okay, so now to make the calculation easier, let us call it as 760.6 into 8.4, which is minus 17 into 35 divided by, not divided by, we won't divide it right now. So on the other half of the, this is multiplied by 4.2. So if you want, you can keep the 4.2 in the denominator here. Okay, so on calculating this, what we'll get, let me calculate and tell it to you. Wait, I have not calculated it by now. 70.6 multiplied by 8.4. So this will give you somewhere 6389.04. Now, wait, I just have to tell you something. Just a second. Okay, audible to you people? Just a second. I'm sharing the screen again. On the same screen again. So this was eventually somewhere around 75, we can say that. So this value was not 17, that was 17 pounds. So this was 75 newtons. Okay, so now let us calculate 75 into 35. 75 into 35, that gives you 2625. Okay, now let us subtract this. 6389.04 minus 2625, that gives you 3764.04. Now it can be divided with the 4.2. That will give you the hip abductor force. Okay, now let us divide it by 4.2. That gives you the total force that will be applied, or by the contraction of the hip abductors, will be 896.2 newtons. All right, again, now we have got the hip abductor force. Now according to the clockwise or the upward directed and downward directed forces, let us see again. So if we have a cane here, let me remove it. Remember this value, I'll just write it here. So HAF with cane will be 896.2 Newton. All right. Otherwise, we have all the other values. Okay. Now, if we have to wait. Wait. All right. So I'll start writing from here. So if I have to calculate the compressive forces or the joint reaction forces within the joint here, so what I'll have to do is I have to equalize the upwardly directed forces to the downwardly directed forces. Okay. Now, the upwardly directed forces are your body weight. Okay. Now the downward and your plus your JRF. Okay, joint reaction. Sorry. Yeah, this is no, not this. This is this. This will be your cane force. Okay, cane force, and this will be your JRF. That will be the downwardly directed forces will be your hip abductor force plus your body weight. So we have cane force to be 75. We don't have a joint reaction force here. We have a hip abductor force that was your somewhere 896.2, and we have body weight force that is your 760.6. Now let us try to calculate this also. Okay, now 896.2 plus 760 will give you 1656. Okay, now JRF will be equals to 1656.2 minus 75. Okay, so when I subtract it minus 75, this will give you 1581.2. Okay, this will give you this value. So this is the final value that whenever you use cane on the contralateral side, you will get this value. Okay. Now, if you use cane on the ipsilateral side, the value of D would decrease. This value would decrease. If this value would decrease, ultimately the whole value which is coming here will eventually increase. Now, if this value will increase, the joint reaction force which is coming out here, this will also be enhanced. This will also be increased. So what you have to do is you just have to keep the other upwardly directed force slightly away from the fulcrum. So you need a larger external momentum here. Okay, you need a larger external momentum whenever you are using any external device for the support or for applying any upward pressure. Lesser is the momentum or lesser is the external momentum, more will be the compressive force within the joint. More will be compressive force within the joint. It will increase, or it will try to go for more degenerative changes within the joint surfaces. Okay, so try to keep the cane slightly away from the fulcrum such that the external momentum is more increased. If the external momentum is increased, the external torque will increase. If the external torque will increase by the cane, the ultimate compressive force will go down. All right, I hope it was a little typical, but I still hope that it must be clear to you people. So we are coming on to the last muscle group of ours here. So that is your external rotator muscle. So we have a lot of external rotator muscles. That is your piriformis, obturator internus, gemellus superior, gemellus inferior, quadratus femoris, and obturatus. This is actually the quadratus femoris muscle, which is being shown to you in the figure here, which is moving. Okay, they are the major external rotator muscles. Okay, now the force produced by the obturator internus compresses the joint surface. The compression force may help to stabilize the joint during active pelvic rotation. I told you earlier also, the direction of force for all the muscles are superior. such that the articular surface of the femur gets fixed into the acetabulum cavity. Okay, so all these muscles are trying or tending to keep to apply a force such that a static and a dynamic stability can be equally provided to the hip joint. All right, so I told you, okay, I had this figure. I thought I didn't had this figure. All right, so this was it when we talk about the hip joint mechanics. Okay, and we are probably done. We have taken 1 hour, and I'm extremely sorry to you people because of the technical glitches which were going on here today, and now we have overcome that. And I suppose if this video was helpful for you, and let me see if you have any questions. You can write your questions here if you have any questions. There are messages of my technical glitches here. If you have any questions, please write. Hello all. Good afternoon, everybody. Okay, if you have any question, you can write. Okay, this video will be available here. Okay, pelvifemoral rhythm and piriformis paradox. Great. So the pelvifemoral rhythm, when I'm talking about, is it can be an open kinematic chain also, it can be closed kinematic chain also. Okay, so whenever I'm talking about the open kinematic chain pelvifemoral rhythm is, suppose I'm talking about the abduction movement and I'm lying in a side-lying position and I'm trying to do an abduction movement of the hip joint. So whenever I try to take it, the ideal range of motion of abduction is nearly 40 to 45 degrees. But at times I am able to take it till 80 degrees also, 70 degrees also, 90 degrees at times also in lean patients. So how those patients are able to take it till those people are able to take it till that range of motion? Ideally, anatomy doesn't provide us that amount of ranges for abduction. So this is by the compensation of the lateral tilting of pelvis and lateral tilting or lateral bending of the lumbar spine. Okay, it is by the virtue of the movements taking place at the pelvis also and the lumbar spine also. All right, this is what is the pelvifemoral rhythm. And when we talk about the piriformis paradox, it is that when my hip is in 90 degrees of flexion, the piriformis muscle acts as an internal rotator. Okay, because the line of action passes or crosses the or passes anteriorly from the mediolateral axis in that case. So whenever my hip is in 90 degrees of flexion, in that case piriformis works as an internal rotator. The rest, when my hip is at neutral or it is into extension, the piriformis works as an external rotator. Okay, because the line of action of piriformis is posterior in that case from the mediolateral axis. Okay, so this phenomenon is known as piriformis paradox. Any more questions do you have? I'll be having this recording on YouTube. If you want, you people can come and see it again. All right, so that was it from my side. For any queries, you people can anytime contact me on any social media if you want. If you require, we can do a fewer things. If calculations are required, we can do fewer things again on this medium only. Otherwise, stay tuned till the next weekend, and in the next weekend we'll be talking about knee joint biomechanics. Okay, so we'll be working on the knee biomechanics in the next video or in the next live session of ours on the next Saturday and Sunday. So stay tuned till then. Be at home, stay safe, and keep learning biomechanics. Thank you so much. I'm Dr. Himanshu signing off from Jaipur Rehab. Thanks a lot.